Welcome to the Careers in Public Health, and this panel will be beginning right now. So my name is Harvinder Kaur, and I'm the Director of Volunteers for the conference. And I'd like to start by having our panelists introduce themselves. We'll have them introduce their names, title, and the institution or organization they represent. So we'll start with Dr. Mitchell.
Good afternoon. I really admire you all for hanging in here. I don't know if I would have had that dedication at your age, but I'm Connie Mitchell. I'm from the state of California. I'm Chief of Policy in the Office of Health Equity in the California Department of Public Health.
Hi, everyone, and good afternoon. I want to echo Connie's kudos for being here on a Sunday afternoon. It really is a testament to your commitment to your development. My name is Arnab Mukherjea. I represent actually 4 hats. I have a postdoctoral scholar appointment at this school, University of California, Davis, as well as UC San Francisco, and I have teaching appointments at San Jose State University and at California State University, East Bay.
Hello, I'm Caroline Peck, and I also work for the state of California. I'm the chief of the Chronic Disease Control Branch and the residency director for our General Preventive Medicine Public Health residency program at the California Department of Public Health.
Hi, my name is Abby Rincón. I'm from UC Berkeley School of Public Health, and I'm the Director of Diversity for our Office of Diversity Services.
Hello, I'm Rob Simmons, Director of Public Health for Thomas Jefferson University in Philadelphia, our School of Population Health, but I'm also from California, having got my master's at Loma Linda and my doctorate at UCLA School of Public Health.
Good afternoon, everyone. I'm Dr. Denise Woods. I am with UCLA Fielding School of Public Health, and I lead a project there called REACH, Racial and Ethnic Approaches to Community Health.
Thank you very much. So we'll start the panel with our first question. What specific careers do you have entering into public health, and what are some of the lesser-known fields?
Can you repeat that?
Definitely. What specific careers do you have entering into public health, and what are some of the lesser-known careers? So someone who's entering public health, what are more well-known career paths that people choose? What are some lesser-known ones that people choose?
I think most people are familiar with a traditional definition of public health being something like health education, health promotion, health advocacy. So a lot of the titles that people have, especially at the undergraduate level or maybe post-undergraduate level, is things like health educator, health associate in terms of research, health promoter, those types of things. That really gets them involved in the population level perspective that we all refer to. That's our common theme. We focus at things at the population level, not at the individual level, and we focus on prevention and protection of health as opposed to necessarily solely treatment of illness. So the lesser known titles, in my humble opinion, is anything. If you are a YMCA basketball coach, believe it or not, you do something in public health, which has to do with fitness among youth. If you do community organizing, again, I always laugh when people on the right say, oh, President Obama was a community organizer. What does that have to do with his qualifications to become President of the United States? And I say, wow, he was a community organizer. He worked with communities, organized around principles of equity and problems that they face. I think that's a very relevant qualification for somebody who is the President of the United States. So again, lesser known titles could be anything from advocacy to doing things in the environmental level. I always tell my students and my interns, just because the word health is not in the title does not make it a public health profession. And it really goes back to what is your understanding of this notion of population level health and prevention. Again, stereotypically, health education, I'm sure my colleagues have a lot more examples of that. But the lesser known ones are really all the things we know have to do with health, but may not have the fancy title, fancy name health in the title.
Thank you very much, Dr. Mukherjea. Is there anybody else who would like to add?
That can't be true.
All right. So move on to our next question then.
Yeah, I can do
Caroline
that.
should add something.
Yeah, I think in the state of California and 61 local jurisdictions, we have quite a few people who, come from different backgrounds. We have people who get an M.P.H. and come into this, come into the public health field. We have people who are physicians who come into the public health field. We have academics, researchers who come into the public health field. One thing I was unaware of when I, got my training and started working at the state was that veterinarians are really critical to public health, because there's this, there's a lot of diseases, especially communicable ones, that there's this relation between the animals, like you think of a dog bite, rabies, causes disease in a human. And really, so veterinarians are in public health. Who else am I forgetting? Social workers, nurses.
Community organizers.
Dentists, community organizers, yeah, lawyers. So those are.
I would just suggest that you can explore the CDC's website, or you can explore the California Department of Public Health, and when you start to see the variety of departments in there and interest areas that public health covers, it's really expansive, and there's incredible opportunity. I'll just share 3 positions that I just filled in the last month or so. One is for a research scientist who's working in our new Office of Health Disparities, and it's going to be part of her responsibility to report on California's status in dealing with social determinants of health, where actually our office was legislated to specifically look at social determinants of health and report on income disparities, education disparities, disparities in child development. We have a whole list of things in our legislation, and that's what she'll be responsible for. I hired a public health educator who's going to be working on a CDC grant called BRACE, Building Resiliency Against Climate Effects, and she'll be working with vulnerable populations who won't be able to necessarily get new air conditioning as the heat rises in the Central Valley, or people who live in areas where they still are very much reliant upon a car, and they won't be able to access lower emission transportation, and how to reach out to those vulnerable populations and to help them as the climate impacts their living arrangements. And then a third one is a health program specialist. She works with our Health and All Policies team. This is an effort that we have at the state we work across 18 different agencies and departments in the state of California, so that all of their new programmatic activities are focused around thinking, how will this impact the health of the population? Her direct responsibilities will be in working with local public health officials to integrate more effectively with local city planners so that they can plan communities that are more healthy. So I just wanted to give you an idea of, these are new jobs that I just filled with new masters in public health, and they cover quite a dynamic range.
Definitely, go ahead.
I'd like to highlight a few resources that you could look at. One is, of course, our national professional organization, the American Public Health Association, apha.org. Another is the Association of Schools and Programs of Public Health and their career net. That's ASPPH.org. I'd also suggest looking at private foundations. I can think of 2 of them, one obviously here in the California Endowment Foundation, but also Robert Wood Johnson Foundation in New Jersey. But not just look at the foundations, find out who they've contracted with, someone similar to CDC, and communicate with those websites and connect who have those contracts from those major private foundations. You'll find a lot of opportunities through those resources.
Thank you very much. So we'll move on to our next question. With the recent introduction of Obamacare, how do you think this will have an impact on public health careers?
You guys all know what Obamacare is, right?
What's that? Never heard of it.
Right. So you should be well versed that there is the Patient Protection and Affordable Care Act that's being adjudicated and legislated as we speak, while our government tries to figure out whether or not it wants to flip on the light switch at some point in our near future. This is a very exciting time for those of us that believe in universal access to care as well as quality of care. It's also a very uncertain time. This level of experimentation has never been done in the United States, and with that will come a lot of challenges in unknown territories. So a few things that may come up. One is the intersection of law and public health. A lot of these things are going to wind up in the courts from the point of view of economics, from the point of view of politics, from the point of view of civil rights. There's going to be many things that happen that we don't know yet. And so people that are versed in the language of public health and the language of jurisprudence are going to be sought after to figure these things out. That's number one. Number two is, how many of you have heard of health information technology, or HIT? We are trying to make our systems more effective and making sure that when somebody accesses the healthcare service industry, that their information is accessible through some kind of centralized information, that we are not spinning our wheels. So there are systems like Kaiser and Sutter and all these different groups, and even now in the public health system, meaning public hospitals, public clinics, that have to figure out how to do health information technology, how to speak the language, how to interface with multiple stakeholders like physicians and administrators and IT people. And there's training programs that are just beginning, but there's going to be a whole host of jobs that are going to rise up as soon as it goes into place. So those are two of many exciting areas, uncertain but exciting areas that I think will be a function of the Affordable Care Act. And I'm sure my colleagues have others that insight that they would probably like to touch upon.
I think another area is, which is going to be huge, is prevention. And Obamacare, or the Affordable Care Act, there are pieces in there that speak specifically to prevention and paying for prevention activities. And things that are related to social justice and reducing health disparities among underserved and under-resourced communities. For example, with the project that I'm working on now, REACH, which again is Racial and Ethnic Approaches to Community Health, we are implementing many strategies that are related to physical activity, nutrition, and general wellness. And this is a population-wide project in which you're trying to figure out how you can reach people in their everyday lives and how you can help that community implement strategies around making the healthy choice the easy choice or the default choice. In fact, what we call REACH at UCLA is healthy by default. And that is where really Obamacare is trying to go. And a lot of projects that are out there now that are being federally funded or even through private foundations are trying to figure out ways to get communities to be healthier, not just individually, but really at an environmental level and at a population-wide level. So that is something else that, just to piggyback off of that.
So I consider President Obama to be our first public health president.
Yeah.
And I think if we continue to have an administration that looks at health as a right and not a privilege, then public health is going to be even more prominent in the years to come. And I'm excited because in the 1960s, Martin Luther King Jr. said, of all the injustices, the lack of health care is one of the most shocking and inhumane. And so for the first time, we're working towards, instead of having 48 million to 50 million people without health care insurance, meaning lack of access to health care, we're going to now start changing that. So public health is actually on the map. We even have a first lady who enacted the first Let's Move campaign, which was a few years ago, and put together the first garden in the White House or had actually Alice Waters from Berkeley come and start sharing how to put together this amazing organic garden and showing children how you can actually have fun learning about science to grow your own fresh vegetables. So between, the president and his wife, we've really started hearing a lot more about public health. So as you go forward in the public health profession, hopefully you will continue to see that public health is going to continue to be grown, it's going to increase in visibility, and it's going to increase in knowing that this is a social justice right of our country. This isn't just a nice to. This is a mandate. And as long as you're working public health, whether it's specifically as an epidemiologist or as a I don't know what you want to call navigator, you will always be working in that focus.
Dr. Simmons, yes, please go ahead.
Getting triggered for some of these comments and going back to thinking resources for you. So now I remembered a resource that I want to give you for the Patient Protection and Affordable Care Act. There are 38 sections in the 2,000 pages of the Act that are specific to prevention and public health. You want to look at those, and I'm going to give you the source where you can find those and take a look at those specific sections, breastfeeding, health, they're just all, diabetes control, all of these things. Go to Trust for America's Health, TFAH.org, and then search for the sections of public health and prevention. You'll see a separate 9-page document which highlights the 38 sections that are specific to prevention and public health. That should hopefully lead you to a lot of opportunities in thinking of who's getting those resources and where can I go contact for potential future employment.
Thank you very much. Did anybody have any other input? All right, so we'll move to our next question. What are some popular areas of public health at this very moment?
I would probably say right now, and this is just maybe because I'm working in this area, it's obesity prevention is huge. As you probably have heard, there are a lot of initiatives now focused on childhood obesity prevention, and we're just now seeing data that it looks like it's leveling off as far as the new cases of childhood obesity and the incidence of that. So I would say right now, nutrition, obesity prevention, childhood obesity prevention, physical activity or physical inactivity, and issues related to that.
Dr. Peck, go ahead, please.
Yes, another federal initiative is called the Million Hearts Campaign, and really recognizing that cardiovascular disease is the leading killer of our population, and that there's disparities, and certain populations are affected more than others. And I think it ties in very nicely with the obesity prevention, because a good nutrition, regular physical activity, not smoking, all those things are what prevent people from having cardiovascular diseases and some of the diseases that happen before you get to that end stage, like diabetes. So I think at the federal and the state level, we're thinking about cardiovascular disease prevention, not just, oh, you have a heart attack, let's see what we can do to treat you, or do an operation to clear the vessels in your heart, but what should we be doing before you get to that point? And focusing on the people who may not have had health insurance or don't live in a community where there's resources where they can be healthy.
And Dr. Mukherjea, you wanted to add something? Please go.
Yeah, I think both my colleagues what they're stating is this term that's common to all of us, but something you should really be familiar with, this phrase, I should say, is called the social determinants of health. And that's something that takes a very unique paradigm in that it takes away the notion that all things happen because of individual behavior and that we can change at the individual level. There's social structures in place, there's cultural patterns, there's political environments that all interact together to dictate, inform, result in either poor or optimal health. And I say that because you see that we may have been worried about heart disease or diabetes, and like she astutely mentioned, it's not about let's clean out your arteries and then hopefully you eat again the way that you did and your arteries get clogged up and we're back where we started. We've shifted the focus to obesity, which leads to things like cardiovascular disease, diabetes, and cancer. Now, obesity is not simply because people make individual choices to eat or not eat healthy. It has to do with whether or not you live in a food desert, whether or not you have access to fresh fruits and vegetables, and, as you mentioned, is the default choice for your $5 a bucket of Kentucky Fried Chicken to fill your whole family, or one head of lettuce that may be questionable for how long it's been at the liquor store from where you bought it. So in California specifically, one of the things, going back to resources, is following where are the major funders providing resources for. California Endowment is one of the major philanthropic funders of public health, and they recently, within the last 3 or 4 years, shifted their focus onto the built environment. What is the built environment? Well, it is how our cities and localities plan. So if we say, please eat 5 fruits and vegetables today, eat 5 fruits and vegetables a day, and do 30 to 60 minutes of moderate to vigorous exercise, well, you know what? You need to have a place to buy those fresh fruits and vegetables. It has to be safe to get there. There has to be a way to get there first, but the way to get there has to be safe. You have to have parks that are used for recreation and not for illicit activities. So counties and municipalities have the responsibility to create those conditions. In fact, the Institute of Medicine, which arguably is a very conservative group, says that public health is not only pursuing optimal health, but creating the conditions in which communities and populations can obtain optimal health. So again, it's not a matter of me telling you what to do and you either doing it or not, and then it's your fault or not. It is, do you have the conditions to access the most optimal health possible? So this, I think, is highlighted throughout this whole discussion, that we're really looking at upstream as opposed to downstream approaches to addressing and influencing health at the population level. And sorry if I misphrased any of you on that. So.
Ms. Rincón, you had something to add?
Yeah, another area that I think is very important to consider as you go forward in public health or whatever your calling is in the health field is that given that we have such a dramatic shift of our demographic population, not only in California, in the United States, but the world, that you are going to be practitioners of public health with a focus not only on cultural competency, but on intercultural competency. Because of whoever you work with, whatever programs that you're designing, whatever you're evaluating, whatever the research scientist programs are telling you that you have to work on, you're going to be working with a population that is going to be primarily populations of color. So if we look at our data, we look at what demographers are telling us, by the year 2040, we're going to be a majority of color in the United States. And we are already that way in some of the metro American cities right now, like Los Angeles, like San Jose, like Miami, like certain cities in Texas. You can look at this, it's very public. So that's who you're going to be working with. This is who you're going to be creating public health solutions for. These are who the groups are that you're going to be developing systems, changes, the built environment work, looking at what's going to matter to make the most effective change. So intercultural competency is the skill for the 21st century, and all of you are going to be involved in this in a big way, more because your careers are going to be taking off very, very soon, if not already. Also, the use of language. You know, we talk a lot about linguistic cultural relevancy, but being able to speak another language, and in California, those two languages are Spanish and Mandarin Chinese. I hope that you speak one of those languages in addition to English, because if you do, your employability is going to skyrocket. Most jobs that we have at UC Berkeley right now, we have 191 positions open that are listed. UC Berkeley School of Public Health doesn't have those jobs. We just get the jobs and we list them. We list them. And I would say the majority of them are asking for somebody to be bilingual. So it's not too late. You can be in your early 20s and still learn another language. And I know a lot of UC Berkeley undergraduates that I work with that are already bilingual Spanish and English. But guess what? They're learning Chinese. Mm-hmm. That's pretty amazing to me. So anyway, just know that if you go forward with that intercultural competency goal in mind, you're going to go very far and you're going to be very effective, and that's what we need.
Thank you. And Dr. Simmons, please go.
And I want to follow up on the demography theme and mention another key demographic, and that's our aging population. And so there's two terms. One is healthy aging, and the other is called aging in place. And Google those, look those up. What does that mean? The opportunities for people in public health in a variety of health and social science careers in addressing the challenge we have as our population continues to age, and the issue of long-term care, aging in place. What do we do with populations that are living into the 80s, 90s, and even now hundreds? That is, you talk about a full employment opportunity in this country. That's another one. In addition to the, in addition to diversity and competency, I wish that more and more of our public health students focused on that particular demographic. It's not as easy as, from my experience, maybe others have. It's not as sexy, quote unquote, as for many students, but it needs to be, because that's really what is super important in the United States.
Thank you very much. We'll move to our next question. As a public health advocate, what is your role in improving healthcare for communities?
Well, coming from the state of California, you know, we're kind of, we don't touch people directly most of the time unless it's through services. So I think, but we can convene people from across California. We can provide data and information to people across California. we can work for policy change at the state level that will impact all Californians. But I think the most important thing we do is have relationships with either our local health jurisdictions and then through them with all the community-based organizations, because public health happens at the local level. And really what we need is communities who drive what we determine are the priorities, what we should be working on, and really we want communities to be empowered to tell us what they want and let us help them to achieve their goals. So I think from the state level, and I hope you guys from other areas talk too, because especially Dr. Denise at the end, because she's much more in connection with the community, but really trying to listen to people who know what the community wants.
Well, I'd like to say that I think I have a very important role in this, which is as the Director of Diversity for the School of Public Health at UC Berkeley, I do a lot of what I'm doing right now and going out and talking to fabulous undergraduates like you all, and I consider myself a talent scout. And what I'm looking for is the talent out there to say, look, you need to come into this field. Let me help you get there by connecting you to experiences, to research opportunities, to internships, helping you to develop a very strong application so that by the time you apply to a school like Berkeley, schools like Harvard and Columbia and Johns Hopkins and UCLA, all the great schools of public health are going to pick you up. And then you're in the position of, which school do I take? So my job of working in this capacity right now is I consider one of the most important that I've ever had in my whole profession, because I know the next generation of public health practitioners is critical for where we're going and where we're headed. So if I can make that difference, and I work with students who are sophomores, who are freshmen. I just came from doing a tour in community colleges in Southern California. So getting community colleges to students to then transfer, to then think about what are all the steps to get into a graduate school, because then they're going to be those practitioners, either in public health and medicine or public health and nursing or whatever else they're going to do. So my job is to really cultivate that, and I can't think of anything more important to be doing at this point in my career at this moment.
You can go.
Oh, sure? Okay. The project that I am working on now, the REACH project, is really a boots on the ground type project. We work directly with communities nationwide. We work with 14 organizations, and each of these organizations has a multi-sectoral coalition. So they have a variety of organizations that they too work with and branch out into their communities to try to reach as many people as possible. So say for instance, we're working with a nonprofit organization and with a focus on children, and then within their group or within their coalition, they may have a church or multiple churches that they work with. They may be affiliated with the school district or schools within a school district. They may have a relationship with the local community clinic. They may have a relationship with business owners or restaurant owners or however. And so what we do is we go into these communities and we help them develop or complete a community assessment as well as a policy scan, which is just to see where their communities are currently as far as their kind of like a health index, to see where they're lacking or where they're deficient in meeting certain, health indicators. And so once these community assessments and policy scans are done and developed, then we move on to the next step, which is to come up with a draft work plan or action plan. And then after coming up with that draft plan, then we finalize it using evidence-based strategies in physical activity and nutrition and also general wellness. So our work, or this specific project, is definitely one that is community-based participatory research, which is another term that you'll probably be hearing more and more about if you decide to go into public health or you're interested in public health. But it's something where you really get the community involved. You don't go in there and tell the community what they're going to do. I think a lot of communities have felt like over the years, universities or large organizations have these researchers who come in there, they think they know it all, and they're telling the communities what their communities are deficient in and what they need to do. And so this project specifically, and many projects that are now within public health, are going in communities, getting community leaders there, and people who have been there for years or have lived there their whole lives, to ask them, okay, what issues are you having? How can we help you? You're at the table, you're helping to make these decisions, and we're working together to come up with solutions for the long term, because really that's where capacity and sustainability is created. If we go in, UCLA goes into a community and we tell them what to do and we're leading everything, when we leave, that project leaves and then it's dead. So you really want to go in there and work with communities and have them take ownership of these programs. So even that when you're gone or when funding runs out, because inevitably funding runs out, when there is no more money, what can you have there that's already instilled in that community? And so the options there are by default the healthier ones.
I would like to springboard off hers.
Go ahead.
Public health is a field that is dependent on data. We focus at the population level. We look at a variety of different health indicators. We look at disease prevalence. We look at determinants of health. We look at how do we measure the associations between X and Y. But inherently, in order to know what the problems are, but more importantly, how to fix them, we have to depend on some sort of data. She mentioned the word community a lot. You hear that, community, population, public. And so one of the things that I focus on is why do certain diseases and indicators affect certain populations in a disproportionate way? Those are called health disparities. Could be among communities of color, could be among immigrants, could be among limited English proficient, it could be among the LGBT community. But very important question, oftentimes that myself as a researcher, the reason why I got into research was that who defines the community? When I check a box on the census, the purpose of that is to collect data. If I check the box Asian Pacific Islander, I'm being lumped in with a whole bunch of people who may or may not have shared characteristics, norms, beliefs, patterns, attitudes, language, religion, et cetera, that I do. So in addition to trying to elucidate disparities that are occurring among at-risk groups, some of the things that I like to hope I focus on is what are the issues that lead to the data that we collect. So inherent in that is the fact that you guys know what those definitions are. You live in those communities, you breathe those communities, you work in those communities. So one of the terms that was mentioned was community-based participatory research. What does that mean? It shifts the research paradigm from a top-down approach to its side that says that communities that are affected have more knowledge than any of us will have about those communities because they go home to those communities, they sleep in those communities, they work in those communities. Maybe we should be asking them the questions about those communities rather than poring over lots and lots of numbers and data sets and coming up with some brilliant conclusion that may or may not resonate with reality. So one of the things that Abby and I both focus on in coming to these events is trying to get you guys excited to pursue those positions of leadership in health so that the perspectives are represented at the table, as opposed to us guessing what's going on. So a shameless plug, and I hate to, but I'll be doing a whole session on community-based research and health disparities next. And I hope that many of you come if you're interested in if you're not, then it's a Sunday afternoon, it's nice, there's things to do outside. But it's a pretty recent phenomenon in the larger spectrum of public health, the notion that a community is the intrinsic part of public health research, practice, evaluation, and all the things that make up the public health enterprise. So in that case, all of you are prepared just by being involved in life to be an effective participant in the public health enterprise.
Dr. Mitchell, I know you had something to mention.
I agree with everything that's been stated here. I thought it might be good to have a specific example. And community, it's really important, the point that was just made, that community can be a general term or it can be more defined. And so I was first in academic medicine. I was faculty here at UC Davis, and then I transitioned, got an M.P.H, and then went to my position with the state of California. And while I was at UC Davis, I was working in the area of family violence. And we did an extensive outreach to domestic violence victims through all of the domestic violence shelter programs in the state to identify what were some of their healthcare needs or what were some of the needs that they had around safety. And we then went to funders to see if we could create some sort of direct conduit from victims of domestic violence to policy and decision makers. So we took the information that we were hearing from women and actually youth to their adolescent children who were in shelters. We compiled all of these needs, and then we got funding, and we convened a state leadership team on domestic violence, which included legislators and public health people and criminal justice experts, social scientists, academicians, as well as the organizations that represent the shelter groups. And for 4 years, we started to tick off what were some of the easy policy changes that we could do on behalf of these women who had articulated, this is what I need. I'll just give you 2 examples. One example was that when they applied for victims of crime funding, which meant if you're a victim of crime, you can get reimbursement for your health care related to that crime. But the women, the way that the statutes were created, the women had to be working with law enforcement, so they had to be actively participating in the prosecution of their abuser in order to get the funding, which clearly seemed like was contrary to the idea that you're a victim of crime and you need help with your health care expenses. We had in the room the officer from the victims of crime. She understood what the issue was. She looked at what regulatory changes that could be made or what procedural changes could be made, and within 1 year, those were all made, so that requirement was completely eliminated. Another thing that we did was that we were finding that women who were pregnant, we were concerned that they were a more vulnerable population. Maybe the pregnancy was wanted or not wanted, and that this group seemed to be a little bit more at risk. And then when we started to look into the data, you mentioned data, we found that we weren't really tracking at all in the state of California if there was a homicide, if the person was pregnant or recently pregnant at the time of the homicide. So we didn't have the data to do the policy that we needed to do. We had a legislator in the room. And so first we tried to work with the people in charge of the death certificate, and they only changed the death certificate every once in a while, and they didn't want to change it. They'd already changed it, and they didn't want to look at it again for another 5 or 10 years. But this particular legislator said, well, fine, if they don't want to do it because it's really important to do, then I'll just legislate it. So she actually wrote it into a piece of legislation as a writer, and within 3 months, that was passed. So we now are required to indicate on a death certificate whether that person had been pregnant or recently pregnant, and that has contributed just an incredible amount of information to us to make policy decisions. So I just wanted, this was a creative kind of public health strategy for getting the needs of one community translated into really powerful policy changes that helped women and men who were victims of domestic violence.
Thank you very much. So the following question will be the last question of the day. For you, what is the most rewarding part of being a part of the public health career? Sorry, the health field. Public health field. What is the most rewarding part for you for being a part of the public health field?
I'm going to start, and then it can go down the line. I was a practicing clinician for almost 20 years and enjoyed every single day of the interaction with my patients and felt like there was no greater trust when they sat and they would talk to me and tell me about their health issues and their health concerns. Oftentimes they would have to tell me about shame of their stigma-based diseases, or they would have to tell me about things that they were embarrassed to share. And I felt that that was an incredible trust. And then as I wanted to learn more and more about how to get more upstream and how to find out better about how to prevent the illnesses and injuries that I was treating every day in the emergency department, I then moved into public health. As I mentioned, I went back and got my master's in public health and now work at a pretty high-level policy making. And I can tell you there's no greater trust than the public trust. The public trust that says every day to me, we trust that you're going to apply the best knowledge that's available out there to solve these really big problems. We trust that you will bring in the expertise that you need. We trust that you will be accountable for the dollars that we are giving you, and we trust that you will evaluate every step of the way if you're moving in the right direction to do this. So it's all about trust, whether it's the individual trust of the client in front of you or the more larger trust of the population that we serve and the taxpayers who pay us to do this work in public health. And that's why I'm totally comfortable with whether I was in clinical practice or in public health practice, because I want to honor that trust.
For me, public health is a career. It's not a job. And what I mean by that is I'm excited about being in Davis on a Sunday. I'm going to be happy when I leave. I enjoy these types of things. So on a personal level, I get to go to work wherever that may be, if it's in the classroom to teach, or if it's in the community to do education, or if it's trying to advocate for a certain policy. I love it. I love waking up in the morning and going to it, and I love going to sleep and thinking out what's going to happen the next day. So it's a fulfilling career. It's not a job that pays the bills. Sometimes it hasn't paid the bills, but I was still happy at the end of the day. From the point of view, I think, resonating with what she said, for me, it's whatever community I'm working with, be it a community of students, that student who finds that aha moment and says, I want to embark on my public health career, or has made the decision that they want to get their M.P.H. in a very hard program and really put in the effort to get into that program. Or if it's the youth in the community who says that I want to change the school system so we get rid of fast food in the vending machines because we know that that's contributing to our health and actually does something about it, where I've enabled the process but I haven't done the process, and I've seen somebody been empowered to do it themselves and then they share that with somebody else. That to me is probably the most fulfilling thing. It's not necessarily a topic or the population I work on, but it's really getting people excited to be able to train, to translate what we learn as methods and theory into action, and not just my own action, but the actions of others for the betterment of their communities. Because that means that, like she said, once the technical assistant is gone, the funder, the researcher, they can go do it on their own. It's sustainable, and that's how it should work. And so that's what gets me excited about doing this sort of work.
Thank you. So we're actually cutting down to a minute, so please go ahead.
Okay. I would say, for me, I have had the privilege, of, like Connie said, working with patients, and now in public health, I have a chance to impact a greater number of people with the work I do. And I, for the past 7 years, have overseen 2 training programs, one for M.P.H. level students to get a fellowship, so it helps them come into the public health career with some work, an internship under their belt of a year, and then also training physicians in public health. And it is so rewarding to work with young people and people coming into the field, and also really trying to attract a diverse group of students to come into the field, because we need that diversity. We don't have all the answers, but you are young, you've grown up in different communities than we have grown up in, just because times have changed. So for me, I think it's working with young people, the youth empowerment. When you go into there is nothing more powerful than a high school student standing up in front of a city council meeting, advocating for something. The youth is just the key to changing our environments. So you guys are part of that movement, and I'm so glad you're here.
For me, currently, it's mentoring and helping applicants like you all to get into UC Berkeley, and it's also advocating on behalf of our diverse students, whether it be with admissions, but whether it's with faculty, or whether it's about a future employment. The social justice component never leaves, no matter what job that I've had. So I would say those are the most enjoyable aspects that I do.
For me, 3 thoughts real quick. What we do, we're doing really important work. We're making a difference. How we do it, we use ethical processes. We have a code of ethics, and that's really important in the processes of how we go about doing what we do. And finally, who we work with. I've enjoyed throughout my career all the various people who share values of social justice and health inequities and disparities and those issues that we try to deal with. So it's so important to work in your career and your profession and really love the people you work with. So those are my 3.
And just to finish out, echoing everything everyone else already said, just the other component to it is being someone who grew up in underserved community and being able to go back to that underserved community and speaking to them about how they can empower themselves and empower their community to become healthier, to live longer lives, to have a better quality of life with the resources that are right there in those communities. And so I think just having that opportunity to help empower communities and make that change is very rewarding. So.
Thank you very much. Can everyone give them a round of applause?